Distance learning courses, I'm not going to talk about laparoscopy, but we've also established a distance learning course in laparoscopy, which we were able to talk about last month in Riyadh and here in Jeddah. But gynecology and obstetrics has really changed dramatically in the last 20 years. D&C has disappeared. All our hysteroscopies now are done in the outpatients, virtually. There's specific targeted therapy for different diseases. Laparotomy has effectively moved to laparoscopy. And reproductive medicine clinics seem to change by the day. They invent new things to do all the time. If you consider our profession as a relatively high-risk one, our interventions cause problems. If you look at the other industries where there are high-risk circumstances, the airline industry, the mining industry, or divers, they just would not tolerate the way we were traditionally trained, whereby you learnt how to tie a suture whilst you were in somebody's abdomen. And as a result of that, nearly all training is a two-stage process, a multi-stage process now, two of which are you learn how to perform the skill outside the woman before you learn to do the procedure inside the woman or the patient. Now, if you want to become an expert colposcopist, laparoscopist or anything, there are a load of different skills you need to learn. And the British colposcopy training course no longer has its major emphasis on image recognition skills, but tries to teach communication skills as well as technical skills, informations, knowledge, decision-making skills, personnel management, and image and anatomy recognition skills. But it's not the most important. The IFCPC, I'll just tell you a couple of tiny things about it. It's about 45 national societies, and I'm very pleased to see that the Saudi Colposcopy Society is a member of the Federation. There are over 9,500 individual colposcopists represented through those 45 national societies, and they come from all over. Now, I haven't got Saudi on this map, because this map was made before, but you can see that those continents and those regions of the world where most cervical cancer exists are least represented in this map. Cervical cancer rates are concentrated in India, Africa, and some parts of South and Middle America. The incidence of colposcopists are high in Europe and North America, and the incidence of cervical cancer is not. The Federation feels it's got different ambitions in different regions. In the developed world, the ambition is to maintain standards, promote improvement through quality assurance, education and training. In the emerging economies, the emphasis of the Federation was different and should be to respond to individual needs, focusing on training and education in colposcopy and the treatment of CIN in support of regional initiatives and from other international agencies, for example, WHO. And the IFCPC doesn't feel that it should tell people in different regions what to do, but should try and help those regions who have particular initiatives they wish to implement and need some help. The Twinning Initiative, which I think might well work here between Jeddah and somewhere else, it's where there are different ways of doing it, but one of the ways is to have a national society to engage with another national society, or perhaps preferably an individual centre that's well established, say in Halifax, would twin with a centre, say in Jeddah, that was just beginning to do colposcopy, and they would share through Skype on a fortnightly basis their clinical cases. And the people who do this have found it very, very valuable. The IFCPC thinks it should examine any and all initiatives that might reduce the burden of cervical cancer, whether they're colposcopic or not, and that we should collaborate, and collaborate. Okay, so training, hugely developed in the developed world, hugely variable in the developed world, excuse me. Structured training has become the norm in Europe, Australia, Canada, and beginning in the USA. There's continued debate about the true value of colposcopic assessment. we believe it's got a role in certain, if not all, cases. And if colposcopy is to be employed, it needs to be done by somebody who's properly trained. As HPV becomes the primary screening tool, as triage using better biological markers will protect an awful lot more women from needing to go for colposcopy, and where primary prevention by vaccination will reduce the number of women who need colposcopy, so we will probably need fewer but more expert colposcopists. But that's perhaps a longer term evolution. Training in the developing world is different. And colposcopy training in the developing world has not been helped, I don't think, comprehensively by the developed world. Traditionally, Western colposcopists like me come to somewhere that's interested in starting colposcopy, perhaps don't understand the local circumstances, perhaps don't understand how the healthcare is delivered, perhaps don't understand cultural differences. After today, I will go away, and how relevant that training is to the local circumstances here is perhaps debatable. The traditional way of training colposcopy is a preceptorship, whereby somebody comes to work in a hospital and spends 6 months or a year in attendance with a colposcopist in a colposcopy service on a regular once or twice weekly basis. In the British circumstance, you have to attend a basic course, you have to attend a laboratory, cytology and pathology laboratory, and then you have continued training in your colposcopy clinic. Now, that's not really feasible for most people in the world. It's increasingly difficult to get medical council recognition and approval for a doctor from abroad to work in Ireland or England or Italy or Canada. It's increasingly expensive for a doctor to leave their own country and go abroad for a year. And therefore we have to think of different ways of teaching colposcopy and other clinical skills. As it happens, screening is just beginning to happen in an awful lot of countries. The value of screening now is being accepted worldwide. And there are an awful lot of new screening programs being established. Some HPV, some cytology, and some simply VIA. As a result of that, fairly rapidly, there are going to be an awful lot of women who are going to need colposcopy. And if they're not subjected to hysterectomy or even cold knife cone biopsy, we're going to need expert colposcopists. So in Africa, in sub-Saharan Africa, we undertook a collaboration between AORTIC, the African Organization for Research and Training in Cancer, IARC, which is WHO's screening arm, International Agency for Research in Cancer, and ourselves. And this group got together and first of all looked at the training initiative that I undertook with Tamil Nadu, whereby we ran a basic course. We provided some equipment to the colposcopy clinic, 2 colposcopy clinics, developed some screening camps in the local villages, had these fortnightly video conferences, and went back and forth to the centres and brought them to Dublin on a number of occasions, then had an advanced course. But it was very expensive. The Health Research Board gave us about £350,000, about $500,000, and we trained properly, I'd say, about 15 people. And that's expensive. Sorry. The video conferencing actually works much better than I thought it would. The internet has got an awful lot better. Skype has got a lot better. There are other video conferencing facilities whereby you can demonstrate a case very easily at the same time as talking to a colposcopist in another country. And I know that the people in Tamil Nadu, and we also in Dublin, found this a particularly valuable way of discussing cases. I won't show that whole. But it wasn't the answer to training large numbers of people who want to become expert colposcopists. So we thought that having assessed the region, having provided the colposcopy equipment, or found a place that had colposcopy equipment, found a population who are being screened so there are enough patients coming through, and worked out the treatment options that were available, and finally assessed the ambitions of the delegates for the distance learning program. We didn't want to train people who are then going to leave. We wanted to train people who are going to stay. We first of all tried to determine the relevant competencies for the region, depending on how much screening activity there was, what the treatment possibilities were, and worked out the balance between what the facilities were and what the need was in that region. The distance learning program comprises a number of lectures over a year. Lectures that have been prepared by global experts, at this time in English. It was a structured lecture series. It was originally internet-based, and every subject was comprehensively referenced. Every lecture was followed by an examination, but a number of questions that the delegates had to answer before going on to the next lecture. And those questions weren't difficult. They just ensured that the delegate had actually listened to the lecture. In the second half of the year, we provided a number of video cases like the one you've just seen. And we thought about intermittent submissions of case presentations from the delegates. At the end of the year, we provided a week-long course in a colposcopy clinic in Cape Town. And then we had an OSCE exam, which assessed clinical management skills, case management skills, dexterity skills, and image recognition skills. We had 20 delegates from Tamil Nadu and 12 sub-Saharan African countries. As I say, the practical course was in Cape Town, and we had 100 patients who all had a significantly abnormal smear in 4 rooms with 4 faculty members and 4 delegates per room coming in and out. So they saw a lot of colposcopy in 4 days, and then had the OSCE. The OSCE was very similar to the IFCPC one. Multiple and varied stations of clinical theoretical management and colposcopic image questions, a high pass rate. The challenges in terms of the distance learning program are how to assess the clinic practice and facilities that are available locally. If a screening program starts in Jeddah today, or a comprehensive screening program of the entire city, suddenly there will be an awful lot of patients who will need to be colposcoped. And there won't be enough colposcopists who are trained. So we should train the colposcopists. However, if you don't have a lot of patients coming to your clinic, it's hard to learn colposcopy. So there's a little bit of a catch-22. You need patients to learn, but you like the people who are seeing them to be trained. And we feel that the way to do this is to have this year-long distance learning course where you get a comprehensive grounding and understanding of every aspect of colposcopy and colposcopic management. Then you have exposure to clinical cases during the 4-day, and then you start working in your practice. Now, it may well be that we should do an advanced course subsequently after people have seen 100 cases, but that's another day's work. The course isn't easy. It needs the commitment of a large faculty. If that faculty are going to come to the OSCE, that's expensive. It needs duplication or translation of the subject matter. We included nurses in the original program. There were only 2. I don't know if nurse colposcopists are appropriate in Saudi Arabia or not. We use nurse colposcopists in Ireland extensively. They're really good. They're as good, if not better, than the doctors. The first course was completed in 2012. The second course is ongoing now, and there are delegates from the Arab world as well as Africa, as well as Europe on that course. The third course, which is now fully prepared in French, starts next month, or the month after. And Laura Flader in Argentina and Maria Jose de Camargo in Brazil are recruiting lecturers in South America and Spain and Portugal at this time to prepare a course in Spanish and Portuguese. And we envisage developing courses in Russian, German, perhaps Italian and Chinese as well. So, by and large, the program is 20 colposcopists, or trainees, a 12-month course, 24 lectures with supportive reference material delivered through the web on a fortnightly basis, a scheduled web-based assessed question after each lecture, and then a load of videos of cases, followed by a 4-day practical colposcopy course. This time it'll be in London, but perhaps it should be more local than distant, and we chose London just because the IFCPC meeting was on in May. An OSCE exam at the end of the practical session, and an IFCPC certificate then awarded. The prerequisites that we have asked for delegates entering the course are that they work in a unit where some form of screening is already provided, such that pre-cancer patients need colposcopy and management. Because if you're not doing colposcopy, it's quite hard to grasp the subject properly. They should have the support of the unit where the delegate's working. They should have a colposcope. And they should have regular access to the internet. Now that's no longer a problem. Everybody has access to the internet now, almost globally, even in Kinnegad in the middle of Ireland. That's all I have to say about the distance learning course. I think that Saudi seems to me to be a very good place to run a distance learning course for the Arab world, because it is the first country to have a national society, I think. It's the only Arab country, I think, outside Jordan. If Jordan isn't probably not considered, I don't know. But Saudi has a national colposcopy society, it has several colposcopists. There's clearly an enthusiasm to learn colposcopy. And it may well be that this is a good place to recruit lecturers to develop a course for the Arab world by Arab colposcopists. Those of you who are interested in joining the course can go to the website and sign up to the course very easily. It's going to change tomorrow. And just to show you an example of how the lectures work, because they're Camtasia recorded lectures. Probably one of the more clear ones is Patrick. Well, now this is a disappointment. Huh? I think the fact that I'm distributing this to an audience outside is competing with me accessing to the internet and playing this video. Do you understand what I'm saying? But he's giving a lecture. You see him in the bottom of the... can you help me? If I turn on the volume, should I just put this in? Try that. and yet you can see his PowerPoint presentation. Now, in fact, the delegates, when we asked them at the end of the course, they didn't like this little picture. They thought it got in the way. So we've got rid of that for the next course. You just see him at the beginning and at the end. But you hear the lecture and you see the PowerPoint presentation. So it's very clear. And you download it so you can look at it over and over again at home. And then, I'm going to stop that because it just hasn't worked. Doesn't like it. And then individual cases are presented to you over a 6-month period with cytology, clinical details, colposcopic images, which are more and more video, and then management options, histology, and subsequent management options. And more questions about how you would manage the case. So after you've seen 25 of those, and you've had 25 lectures, you really have got the beginnings of an understanding of colposcopic management. And then with a week in a clinic, 4 days in a clinic, and an OSCE exam, we think that those who pass the exam are worthy of a certificate, an IFCPC certificate.